Thank you for being here and welcome to the Artificial Intelligence Precision Health Institute Affinity Series talk. We've been holding these for over 2 years now, first Friday of each month. And we try to bring together AI researchers in a variety of fields with clinicians and advocates with the goal to foster collaborative interactions to solve problems in cancer that were thought to be unsolvable a decade ago before the broad use of deep learning in AI. The format is roughly a 30 to 40-minute talk to give plenty of time for discussion afterwards in the 1 hour time period. If you have any feedback for us on how we could do things better or even speaker suggestions, please send that to either myself, John Shepard, or Dr. Sadowski at the emails below. We co-chair these sessions. These are sponsored by the University of Hawaii Cancer Center and on the Kaka'ako campus of University of Hawaii. Here's our building, and also as part of that, the Artificial Intelligence Precision Health Institute is also part of the Cancer Center, where we train and encourage students to work in healthcare and applying AI to healthcare problems. It's also sponsored by the Hawaii Data Science Institute, which is a broader program within the University of Hawaii to support data science education. And we have a very generous compensation for our speakers of a beer stein with our logo on it. And we find this to be very effective to get the best speakers for you. The paper of the month is the that we came across that brought today's current speaker to our attention. And it is called Re-Explain Translating Radiology into Patient-Friendly Video Reports. And I encourage you to read this and any of the other papers that our speaker has today. So it's my pleasure to introduce today's speaker, Dr. Pranav Rajpurkar, a leader at the forefront of artificial intelligence in medicine. Dr. Rajpurkar heads a lab at Harvard and takes a deep computational approach to solving biomedical challenges, drawing on techniques from computer vision, natural language processing, and structured health data to develop intelligent systems that go beyond assistance, systems that can fundamentally reshape how clinicians interact with AI. His collaborations span radiology, cardiology, and pathology, where he has helped pioneer some of the earliest and most impactful demonstrations of deep learning, achieving expert-level performance. Just as importantly, he has studied how these systems influence clinical decision-making, emphasizing both algorithmic performance and AI collaboration. He earned his BS, MS, and PhD in computer science from Stanford, and his lab is currently advancing the field through research on training algorithms in data-scarce settings. So please join me in welcoming Pranav to our lecture series.
Thank you so much for having me, Dr. Shepard, and thank you to you, Dr. Sadowski, and Ariana for extending the very kind invitation. What I thought I'd do today is share certainly Rexplain, which you shared or at least previewed with the rest of the group, but I want to give you a sense of what I find most exciting in this space and some of the ways in which I think the ideas that we're pursuing might be in some ways contrarian to the long-held beliefs in our space. And so that's where I want to start today with the title of the talk on rethinking AI-human integration in radiology. Just over the past couple of years, one of the things that's challenged my personal view of the future of this field is that it's not too far-fetched for me to imagine that the next generation of AI systems will in many ways be super intelligent. And it starts to beg the question, is the best way to deploy these systems under the supervision of humans? I first got interested in this question in 2021, and this was long before it became very clear that this world could be possible. And it was actually a few faculty at MIT who started working together with each other, and I joined them in their effort to test the fundamental assumption that AI tools will enhance physician performance when providing helpful diagnostic support, and actually try to formulate a formalization of the question, does the AI plus the doctor outperform the AI or the doctor alone? And over the course of the next 2 years, we set out on this journey of testing this experimentally. And our experimental setup was that we would look at the fundamental task of chest X-ray interpretation, in which we would have the chest X-rays as well as AI predictions on several different conditions. And for this study, we were going to be able to provide the indication for the exam, which is often the reason for the exam, as well as any available clinical context. And in addition to that, we're going to have the vitals and the abnormal labs be displayed to the interpreting physician, which in this case was going to be the radiologist. Now, this was a pretty large scale effort, so we recruited 227 radiologists to interpret 15 conditions on chest X-rays with and without AI assistance and with this clinical context. So the first result that sets the standard here is to try to understand how well the AI model performs by itself. This is a set of cases it's never seen before, and there are expectation was met that the AI performed pretty well. In fact, if you put it head to head in its performance to radiologists, it outperformed 78% of the 227 radiologists. That's a good start. But now to get to our primary question, which is now when this model is supposed to help people, how much does it help people? And we found that the average treatment effect over the population was 0, which means that on average, there is no improvement in the performance of the radiologists using this algorithm. Turns out that there is large heterogeneity between the experiences of different radiologists, not anecdotal, but quantitative differences in their performance improvement. If we try to understand where there is improvement, it's actually when the AI shows high confidence. And if we look at where there is a deterioration, it's when the AI shows prediction uncertainty. So that's interesting. It's telling us something about when the AI and the downstream collaboration is working and when it's not working. So in this follow-up study in Nature Medicine, what we tried to understand was whether there was a way to predict who was going to benefit from AI assistance. Because if we could do this, then the way we would do deployment is to do an initial assessment where we would ask a radiologist some questions or collect some information about them. And then we could use that to decide whether or not to give them AI assistance. That would be pretty cool if we could do that. And for a long time, people have held this belief that there is a relationship between whether or not this collaboration will work and people's experience with AI tools, or whether they're earlier in training or later in training. So those are the kinds of questions that we focused on trying to answer. Okay, so our main finding was that experience level actually did not predict success with AI integration. Specifically, in this study with 140 radiologists across institutions who came from various specialties, a variety of experience ranges, we found that years of experience, the specialty in thoracic radiology, or their experience with AI tools were all not predictive of whether or not they would find improvement as a result of AI assistance. And what this goes to say is that while there's a lot of heterogeneity, we don't really have simple methods to be able to predict who is going to benefit. And so we need to think about how to measure individual responses and how to therefore personalize the implementation to the subsets of radiologists who will benefit as a result of assistance. Now, we're not the only ones to show results like these. In fact, there have been a slew of papers now that showcase failures in human AI integration. And this has been studied across medical specialties now. One of my colleagues at Harvard, along with colleagues at Stanford and Virginia, had a result that was initially pre-printed and shocked the community, but then later published in Nature Medicine as well, that showed that on diagnostic cases, the combination of the physicians and AI, while slightly better than the physicians alone, actually much underperformed just having the AI make the differential without physician supervision. I think, as is the case with many of these studies, there are limitations between what we can measure in these controlled environments and what goes on in the real world. But the evidence is to an extent now that we should at least consider the question that the combination of physicians and AI might not be better than either alone, and start to ask the question, what happens if that's true? I want to share with you some large scale trials because they go to the heart of some of the evidence base here. So, this is the Messiah trial, which was led out of Sweden, which is an RCT of over 100,000 women that uses AI to determine whether cases need to be read by one human or double read, and double reading is the standard in Europe. And this is all based on the risk assessment given by the AI model. And what was found here is that this AI-driven approach led to a 29% increase in the cancer detection, led to a radiologist workload reduction by 44%, and with no increase in false positives. So very positive example of being able to decide through AI whether something should be read by one or two humans. And this goes to say maybe there's some hope in a integration strategy that thinks about things a little differently, where clearly we're starting to see one example of success. Also, sticking to mammography, here's another study. This one's called PRAME. PRAME was led out of a group in Germany, and this was a real-world effectiveness study across 12 German screening sites. This, I believe, was 300,000 women. And this is trying to examine not what happens when people are forced to use AI, but what happens when AI assistance is available. So what's unique about this experiment is that the radiologist can decide if they want to use AI on a particular case. And what they found was that the radiologist decided to use AI for a lot of routine cases, but when there was a complex case, they decided not to consult the AI output. Almost the opposite of what I would expect, but an interesting behavioral point that the study, in fact, makes. The implications of this is that people, whether we like it or not as AI developers, start to develop intuitions for when to use AI and when not to use AI, even if they're not being explicitly told to use AI. And that, I think, is going to be an interesting and important point for us going forward. So earlier this year, my colleague Eric Topol and I got a chance to write an article that was published in the New York Times that provoked the question, should we think about a deployment setup in which we don't force a collaboration between an AI and a human, and somehow still be able to succeed in the integration and somehow still be able to synergize between the expertise of the human and the expertise of the AI. And the basic proposal is that of role separation, in which we're not thinking about how to provide AI output alongside human interpretation in a way that introduces this cognitive friction, but a fundamentally different approach of saying we're going to separate out what the AI does and what the human, or more specifically, the radiologist or doc might do, that gives them complementary yet separate responsibilities in a diagnostic workflow. So I want to share with you concretely what this might look like. In particular, I want to dive into examples of three particular models of role separation. Number one is where we're going to have AI do initial review and documentation and then bring in the human expert. The second one, where we're going to have the human do the interpretation and we're going to have the AI be responsible for enhancement and education. And then a third model, which is a case allocation model, in which we're going to decide for a case whether it should be read by an AI, by a doc, but not the doc with the AI, or maybe with the doc with AI. And I want to show you an example from that. Okay, so starting with model one, I want to use the example of one of my PhD students' recent publication in Nature Medicine, which was called CraftMD. And what CraftMD does is it imagines a world in which a AI model is tasked with the uh, task of asking patients questions about what they're experiencing and getting to a point at which it's collected all the right data and it's able to come up with a differential for what are the most likely um, reasons for their condition. Basically, get as close as possible to a diagnosis. And the deployment idea is if you can get to that state at which you've had the conversation with the patient and you've already collected the right ideas, right information, the visit to the doctor with a human doctor would be fairly easy in terms of the time that it would take. Okay, so if we think about this from an AI perspective, what this is really doing is it's changing the way we're thinking about evaluating AI. And I want to play you this video of exactly what the paradigm shift looks like. So traditionally, when we think about evaluating large language models, we have case vignettes and multiple choices in which the model is tasked with selecting the right answer. But clinical medicine doesn't work this way for a variety of reasons. And what we're going to try to do is have a more realistic assessment. In this realistic assessment, we're going to have patient AI agents. They're given their case, so what they should behave as. And when asked questions by the clinical LLM, they have to stay true to the vignette that they're given and answer accordingly. The clinical LLM is, of course, tasked with asking the right question. And when it's asked the right questions and collected the right information, coming up with a final diagnosis. Now, in this case, it was the same case as before. And what we have done is by presenting this information in a different way, we've actually got the LLM to make the completely wrong diagnosis. Same case, completely different results. And it turns out this performance drop is pretty significant. At the time at which we did our study, GPT-4 was the top performing model, and it actually experiences a big difference in performance when it's given all the information up front versus when it's tasked with collecting all the right data from these conversational interactions and then coming up with a diagnosis. And that should be scary for us in many ways because evaluation does not equal how people are thinking about deploying these clinically. So that was the first model, the model of saying, let's have humans take care of the process after where the AI has made, the question gathering and the diagnosis suggestion. And I've, through that example, also shown you that we have a distance to go because before this becomes a reality. But that's fine. That's the theoretical model which we're thinking about. So let me now shift into the second example in which we're going to flip the order. In this particular case, we're going to have the human do the task of actually writing out the radiology report after looking at the image, and now enter AI. And this particular project was motivated by experiences that my lab members, as well as my own experiences in getting a radiology report after a scan, which is that you go get a scan, you get a report, and it's got multiple lines of information that patients and their family members just cannot understand. In particular, what's difficult to understand about it isn't the part that's easy to solve by pasting it into ChatGPT and says, explain this to me. It's to be able to actually correspond the findings on the image with what's described in the text. And so this got us to start thinking about having a radiology report that actually looked like a video that would be provided to the patient upon them actually receiving a report in text. Why not think about getting a complementary video as well? And so here's what that looks like. I'm going to actually keep this muted and I can narrate over it. So here we have a video radiology report. This is semi-automatically generated with AI right now. You see a virtual avatar at the top that's actually describing to the patient what the findings are. You see the patient's CT scan on the left, which is highlighted in this particular area, the clinically important finding. On the right is a 3D rendering where the patient gets to see in 3D where the finding actually lies in space. And now what we're doing is we're comparing a normal scan on the right, which is age match, with the patient scan on the left to give them a sense of what is actually different. Very powerful idea. And just as of this week, we now have IRB approval to allow us to have patients send their scans to us along with the radiology report. And we will, as a service, for free, generate this video radiology report for them and then collect their experiences from having this educational content. Now, it turns out when we ask physicians whether they would be comfortable with a change in workflow as a result of having these video radiology reports, this gives us some very insightful ways of progressing here. So this is the survey that we did with the questions that we asked. And what was overwhelmingly positive was that connecting the explanation with the image, most people believed would help improve understanding. If you go to the close to the bottom of the list, the strong disagreement is with the statement, I am comfortable providing this video to patients before the visit. Now that's interesting. Why would physicians, and in this case, interventional radiologists, not be comfortable with providing this video to patients before their visit? And the number one factor here was that they felt that by being in control of sharing how the patient should think about their finding the very first time they meet with them, they would be able to address a lot of the patient's concerns as it would relate to potentially clinically insignificant findings. This is an important learning. So if you have atherosclerosis or degenerative changes that are often mentioned in the report, perhaps we don't want to include them or focus on them too much in the video. Patients are obviously going to be paranoid about their own health as well as their family members' health. That's useful feedback. So part of where our lab thinks that the world is about to change is with the rise of generalist AI models. In a lot of ways, the findings we are making about human AI integration might all look different 1 or 2 years from now when the kinds of systems that we are interacting with change dramatically to what they look like in practice today. Generalist AI models in particular offer the following value, which is to say, I can try to solve a lot of problems with a single interface and with a single backbone. That's the distinction between generalist medical AI and what is, in many ways, narrow AI, the previous generation of models that were trained on very particular tasks to do very particular things. And we can start to think of having these single models that are responsible for comprehensive reporting, for context-driven analysis, for risk prediction, and maybe even treatment suggestions that might get us to a superhuman level of performance someday. More recently, we've been thinking about how this looks particularly when we're interested in generating language as a way of communicating with the physician and having these models be responsible for looking at both imaging and non-imaging data alike as part of one unified architecture. We refer to this AI resident paradigm where the resident is responsible for coming up with a preliminary report or guess, and then that's supervised ultimately by the attending. The difference is we're not doing this on just one narrow task, like detecting a lung nodule, but it would be for something like producing a whole report. So this is a technology that's being worked on by several labs right now in order to work with different kinds of medical data as input and be able to generate different kinds of medical artifacts as output, including reports, including explanations, including annotations. And what I want to share with you today is one effort from our lab, from one of my former postdocs, Hongyu Zhou, who's now on faculty. Um, and what we thought about creating at the time was a single model that would be able to demonstrate really accurate performance across a variety of conditions and a variety of tasks across a variety of modalities that have traditionally required specialized models to be able to solve well. And with MedVersa, the ambition was insane. We're going to have vision inputs of different kinds. We're going to have language inputs of different kinds associated with some vision inputs. And we're going to try to solve vision language tasks and vision only tasks together. This required us putting together a data set of about 5 million medical images across 10 modalities, 29 million task instances, and we looked at a set of 11 canonical benchmarks. This included image captioning benchmarks. This included longitudinal captioning benchmarks, which require you to take a look at the prior as well as the current scan, region captioning, open-ended VQA, chest pathology classification, skin lesion classification, anatomical structure detection. This requires putting bounding boxes, object detection for chest pathologies, organ segmentations, looking at skin lesion segmentations, abdominal organ segmentations. So these are pixel level tasks now. And what we showed was a unified training process with a unified architecture that set a new state of the art across all of these different benchmarks. Beyond the static validation on an existing benchmark, one of the interesting questions for us is, are we on a certain set of tasks good enough to be able to be indistinguishable from a human output? In this particular study, what we did was we looked at a set of cases where there are human-generated reports, and we had AI generate reports from the images for the same set of cases, and we gave those pairwise to experts, where one of the pair is going to be a human report, one of the other of the pair is going to be the AI report, and the human is blinded to the origin and has to say whether one report is better than the other, which one, and whether they're both clinically equivalent. And what was found was that overall there was equivalence in the report 64% of the time, with the AI report being preferred 7% of the time, the human report being preferred 29% of the time. I would personally love to see this study be done every year with the latest and greatest model, because I expect that this is going to look very, very different, and probably already looks very, very different from the time that we did the study. The example that I've been interested in of a task which I'd like to conquer, and several folks have made incredible progress on this over the past few years, has been that of drafting reports in radiology, looking at the images. And on this particular, in this particular work, what we did was the model, which is called MedVersa, generated these reports, which the human then has to modify to get to a final report. And we showed that we could generate time savings with this model. And interestingly, if you use something like GPT-4o for this task, you actually make the time taken by the radiologist worse than just starting from scratch. And that goes to talk about some of the difference between the general models and the specialist models here that we can develop within the domain. Now, this is a task that's so interesting that we've observed incredible attention and progress. And for that, we've set up this public leaderboard called RexRank. So RexRank is a public benchmark where we have people submit models on the task of chest X-ray report generation, and we evaluate them on private test sets that have never been exposed publicly. And so that allows us to, with high unbiasedness, evaluate the progress of these models across a variety of different settings. And the generation of these complex clinical data sets and making them public is near and dear to what our lab does. another effort. This is co-done with my colleague David Kim at Stanford, has led to the MC-Med dataset. MC-Med represents in certain axes the most comprehensive public data set of emergency department visits, which includes continuous monitoring data as well as complete clinical context for 118,000 patients, or rather visits from 70,000 unique patients from the years 2020 to 2022. So capturing a lot of what happened during the heart of COVID. One of the efforts that our lab has been leading very quietly from 2021 has been the Medical AI Data for All initiative. So this is an initiative where we partner with hospitals from all around the world and create these, curate these data sets that allow us to assess the applicability and the generalizability of machine learning models to data from different institutions and allow us to get at where they actually fail when deployed or attempting to be deployed globally. And we've done this across several settings, and we have these data sets getting ready to be released publicly for other people to hold such similar studies and to be able to test the generalizability of their models. In addition to my academic efforts, one of the things that I've been interested in is bringing technologies like these into practice. As part of that, I co-founded a company in 2024 called A to Z Radiology AI. And there we're interested in the task of being able to look at complex CT scans, such as abdomen pelvis CT scans, and be able to get at the heart of reporting the key clinical findings. I want to show you a 30-second demo of what the system is capable of. So this is an abdomen pelvis CT, and on the right, an AI model has been able to generate the key findings. When the radiologist clicks on those findings, they're able to navigate to that area of interest and able to verify that the finding is in fact present and be able to confirm or deny the presence of it. And this serves as a way to quickly be able to generate a report for the for the treating physician to be able to look at. This idea of creating these foundation models doesn't just stop in the digital world. There's a lot that's trying to bring this into the physical world. And this is not from my own lab, but this is a work that's trying to create a video level surgical foundation model from Hao Chen's lab at HQST, and goes to just talk about some of the ways in which people are already thinking about getting into procedures as the next frontier. All this being said, I think within the US, one of the things that's stopping us from experiencing these systems being deployed nationally is the reimbursement mechanisms basically being non-existent. There are only 8 AI-CPT codes today, and that's something that we should expect needs a lot of revamping in terms of reimbursement if we're to see a big delta in terms of adoption. And there are many ways in which that reimbursement might happen. We wrote about this in a paper that was published late last year in NPJ Digital Medicine, which involves ideas like MPFS coverage, IPPS or OPPS NTAP, and just care coordination through transitional care management codes. And it's a complex topic, and certainly one that needs a lot of attention from policymakers and many stakeholders if we're to make a dent here. One of the things I'm excited about is the work that's coming recently out of our lab with what is the largest public chest X-ray data set called REX-Gradient. REX-Gradient is the first data set to cross 100,000 unique patients in terms of chest X-rays and available uh, for free on the internet on Hugging Face, and that might be a useful resource for some of you here. It has data from three different health systems. It's completely de-identified, and one of the unique things about it is that we have high quality reports associated with each one of these scans, allow the community to have some interesting image language work or be able to do some interesting evaluation around these patients. We've also developed a VQA data set on top of this recently to get at the question of how well can AI systems answer particular specific questions about these images. And this is an example of the kind of question that might be present in this data set. And we tested a bunch of models on this task to basically find that it still remains an open challenge. And right now, the models on VQA are equivalent to radiology residents and have a gap to fill to attending level. But it was only recently that two models got to a point at which they were able to rival the radiology resident performance on this particular benchmark. So in this benchmark, one of the things that's unique is you can look at different kinds of questions and look at substantive questions where the models have a lot of room for improvement. And you can think about it from the perspective of different systems, respiratory systems, cardiovascular systems, medical devices, and musculoskeletal. And we spend a lot of time coming up with the systems for generating these questions in order for them to be very clinically aligned. I just want to share now over my last set of slides a hodgepodge of different interesting work done by some of the trainees in the lab. With these models that can generate reports, one of the big challenges is how we detect hallucinations. And so we've started a line of work on being able to detect these hallucinations and then to be able to fix them. RadFlag was a method developed by one of the undergrads working with us out of Stanford and out of Harvard to be able to use temperature-based sampling to detect inconsistencies and flag hallucinations. And the core idea is to be able to sample with high temperature and to be able to vote on entailment and then to use conformal risk control to pick the threshold at which you would decide that something is likely hallucinated. And we can sometimes fix these hallucinations. And this particular idea that was work done by another undergraduate in our group was thinking about solving a particular kind of hallucination where these models make measurement hallucinations and be able to fix these measurements using a specialized model. And at the heart of this was this idea to query the generated reports for these measurements, to be able to generate code to call the specialized models, and then to be able to update the report with the output of these specialized models. And in this particular study, we showed that we were able to massively improve the accuracy of measurements using this paradigm. A lot of our upcoming work is looking at 3D medical images, relationships to video processing, how we can learn from that literature and contribute to it to be able to really think about tackling these kinds of scans and data shapes that are or that have been considered computationally infeasible for AI models to get at. And this work in NPGA digital medicine covers some of the ideas that we've been contributing to, as well as learn from our colleagues in terms of how to do this modeling really well. And this doesn't just apply to static settings, in which case the image is collected and we're post-processing them. This also applies to real-time procedures. So some of our work looking at endoscopies now allows us to think about how to put in these models such that they affect what the endoscopist is going to do next and where they're going to navigate their scope to. Um, and one of the last ideas I'll just share is I think we're moving towards a world in which we're going to have these different agents in healthcare that are going to be responsible for different aspects of clinical operational workflows. And this work that we published in Nature Biomedical Engineering basically tries to imagine a world in which we have multiple agents that all have to coordinate with each other in turn to be able to operationally provide care, and just a proposal for what this design could look like such that a patient care could really have the physician focus on the conversation with the patient, and everything else in the background is the responsibility of different agents that actually have to communicate with each other during patient evaluation and prior to and after care. So I'll end there. I'll just share one of the ways in which our lab works with a lot of smart people is through our training program called the Medical AI Bootcamp. This is over 6 to 9 months in which we work with medical doctors from all around the world. And traditionally, AI trained students at Stanford, Harvard, and MIT, but we are slowly opening that up to people from other institutions as well. And we've had people in the past that have done that. So if that sounds like something that's of interest to anyone in this audience or to your networks, please forward that along. But I'll stop there and thank you so much for having me. And I hope this was at the very least interesting, and certainly some of the things that I'm most excited about and keep me up at night in terms of thinking about what should happen next in the field and in the world. Thank you.
Wow. I wish we could give a big round of applause. It's hard to do that on Zoom, but thank you so much for an hour or almost an hour of your time on the work you're doing. It's really, really inspiring.